Tigers. So he consulted local physicians at Aligarh, took some treatment, but he got not relief. And that physician actually asked him that you should take to the higher center. So his sister lives in Ghaziabad, right? So somehow he contacted me, and I admitted this patient at my center. So other history that patient was also giving the dark color urine, possibly because of dehydration or some liver issue, because patient is a chronic alcoholic. So this is just a brief about this history. Move नहीं कर रहा है slide. Okay. So in the past personal history, patient gave no history of any significant comorbidities like hypertension or diabetes. He's an app developer by profession, and is a chronic alcoholic. The most important is a chronic alcoholic, consumes around 160 to 180 ml of whiskey. 160 to 180 ml of whiskey most of the days of the week for past 8 to 10 years. I actually advise the brand, कौन सा brand लेते हो भाई? तो कहता है वो जो आता है मैकडोनल्ड #1 वो लेते हैं, बट उसके सिस्टम होती है उसकी भाई बोलती है कभी कभी ना लोकल जो होता है वो भी लेता है कभी कभी. So most of the time she took it and is almost for the past 8 to 10 years. So I would also like to ask Dr. Vibhu that how many years the patient could consume this much alcohol without development of chronic liver disease? Just your comment, Dr. Vibhu. Mike. The mic.
Be it alcohol, be it fat, be it meat. So there are two hits which are needed. One is the presence of the fatty factor, like in this case alcohol, and the other are genes. So
Shabu, mic दो यार, क्या कर रहे हो? They should have been ready, right? Ready, should have been ready.
as I said, in fatty factor is one thing, but then there is a very important role of genes also.
Right.
So we would definitely find always encounter a patient who would say that मुझे CLD हो गया था तो उसमें खंभा भी था उसका नहीं हुआ. So it is about the genes also. Similarly, when we encounter a patient who has developed cirrhosis secondary to alcohol use disorder, alcohol can also if you are risk of developing alcohol associated liver disease is much higher than your peers because the other has developed alcohol associated.
It's very important point actually, right? Sometimes patients develop CLDS, some patients do not, and they consume the same amount of alcohol. So Dr. Vibhu has rightly pointed out that sometimes genetic factors also play some role in development of chronic liver disease in the future. I think it's a very important point that he made it out.
There are any number of genes which are involved in metabolism of alcohol. Number one, then there will be genes involved in inflammatory pathways in the liver, fibrotic pathways in the liver. All of them contribute to fluid levels in the liver.
Perfect.
We do not understand them well enough.
Right. So it means that if we are social drinkers, and sometimes we had a gene in me, so I may get CLD in future.
Most of the patients these days are not pure alcohol use disorder patients. We have a combination of alcohol intake, very significant to alcohol use disorder, and significant overlay of metabolism.
Right.
It is there is a new term. One is because we are all the way severely it is pure metabolic associated to day-to-day liver disease. The other term associated with MET oil.
Right.
So it is combination of alcohol, some alcohol and some alcohol.
If you go to the vitals, his weight is around 50 kg, 40 to 50 kg. So he's a lean build, right? So the patient is obese, have the metabolic syndrome, and taking alcohol. So definitely they had more chances of getting this alcoholic disease. I think good point, Dr. Vibhu. And is there any testing available for this genes, Dr. Vibhu? Is the genes available that what I could check my genes and I could develop the CLD?
The way we are progressing, probably in the next 20-30 years, even that will be able.
That would be possible.
There are companies now started claiming in business trial, you will know your, but the ethical
Issues.
that is not how very big to be. But yes.
So it's important that if I don't have a gene, right? Okay, so I can take alcohol.
Thank you, down the line, you would have this kind of a test. ठीक है, आ गया।
People are working there. डॉक्टर साहब कैंसर का कोई बता दिए कुछ टेस्ट के मतलब मुझे कैंसर होगा या नहीं होगा, राइट? तो मुझे लगता है कि उसमें कैंसर नहीं होगा तो डेफिनेटली आई वुड बी रिटन दिस टाइम अल्कोहल वुड एक्चुअली से दैट इफ आई फील दैट ओके मैं जीन नहीं मेरे अंदर तो आई कैन टेक अल्कोहल एंड लिटरली राइट सॉर्ट ऑफ थिंग,
It might not have genes for chronic liver disease, but it may still have genes for cancer protein in transport.
Yeah.
It is that is chronic.
In fact, in recent WHO guidelines, they say that even a single ml of any alcohol is harmful. They don't say okay, alcohol is good for heart, but it's not. WHO said that any amount of alcohol, any brand is actually it is deleterious. So I think we should take a pinch of salt, like right, okay. So this is a chronic alcoholic, also chronic tobacco chewer as well. So the patient would actually had the chances of developing some cancer elsewhere also. Then gave history of pain and tingling sensation, both lower limbs not investigated, right? Patient promptly developed alcohol neuropathy. The patient did not have a record. They didn't test it for it. He went to Max Vaishali 2 years back for the symptoms. He advised some testing, some advice that you should leave alcohol because probably this is causing neuropathy. So he did not listen to them and continued to on taking alcohol and never investigated for it. So patient was little stubborn sort of thing. Shambhu ये नहीं चल रहा बेटा, क्या कर रहे हो? It's not moving. शंभू ये स्लाइड ही चल रही है यार, क्या कर रहे हो? Should have checked now. It's wasting time. स्वाति just ये चलेगा नहीं है next time से. It's being recorded, right? Right. So just examination, patient is a thin build, around 40-45 kg of weight, and he was sick looking, right? His pulse was 112 per minute, BP was low, 160, possibly because of dehydration, because he's passing good amount of stools for at least a week, and on examination was markedly dehydrated, and there was no rash, something like that. So on SpO2 it was 92% on room air SpO2, and on examination marked pale was there. Icterus was there, edema was there, and there were no lymph nodes. Just CVS is okay. Patient conscious oriented, because I thought that patient is chronic alcoholic, so patient was not in any encephalopathy right now. In examiner serous, power lower limb was 4+, reflexes, ankle reflex, process the patient had associated alcohol neuropathy, and that's why he is having this. On per abdominal soft, non-tender, liver spleen was not palpable. That's most important. I could not find liver spleen on this thing, and there was no fluid. So patient probably not having giving history and signs symptoms of chronic liver disease. So patients are chronic alcoholic for so many years actually. So this was a lab investigation. We could do hemoglobin around 8, right? On examination, MCB 97 is normal. TLC was 0.39, 390. And I was shocked to see this report, because when the patient came and the lab person actually did see this thing, so he was very surprised also. So he could not issue the report that day. Yet I need to look into the pathologist, and the pathologist gave the report next day. Yeah, actually TLC was very low, 390, right? In which neutrophils were around 48%, lymphocyte 35%, monocyte was 35%, and platelet count was 25,000 only. Retic corrected was 0.5% and CRP was 150. So this was the report, and you could see, you could make it out the patient is having marked pancytopenia, right? The patient having fever, loose stools, vomiting, dehydrated, chronic on the setting of chronic alcoholism, presented with this report. So, Dr. Vibhu, I would ask you, what could be this possibility regarding this as far as the gastroenterologist is concerned?
If I keep this CBC report, and in terms of we have a if I leave this CBC report, I think in terms of if we have a patient of alcohol disorder, because there are cirrhosis, we have to evaluate on that, and has developed some infection. Now that infection is somewhere, maybe GI sepsis if you are for diarrhea and all. But looking at this report, the TLC of 390, primarily hematological things were on my radar. So instead of evaluating his bowels or things like other thing. Some logical issues needed to be.
So had it been CLD, right, the patient have a spleen, so you would see that hyperspace in this type of picture, so low TLC.
So, yeah, so no TLC are not seen in hypersplenism, not usually seen in hypersplenism, not probably the right person to talk about.
Rohit, you seen in hyperspace in this type of TLC, CBC report?
Sir, in hypersplenicism, actually, mostly it is the, anemia and thrombocytopenia because of the, secretion. But the TLC, it is so low, it is not, it can occur if there is a concomitant infection.
Okay.
It's of hypersplenism rather than standalone, such a low TLC. So basically, initially, if you see the history and do the basis of exam, you basically think that there is a toxic insult to the marrow, and it is like alcohol, it is a real marrow suppression because there was no spleen or liver at the initial exam.
Right.
Eventually, it came on later.
Right.
Initially, it was not, but eventually, once the scientific was what side and all, we came later on. But hypersplenism does not appear like this.
So alcohol could lead to this picture of this so low T.
It can. Alcohol is a marrow suppressor. And alcohol causes toxic insult to the progenitor cells, and it can basically what really can it can cause sometimes MDS, myelodysplastic syndrome.
Right.
So there is the precursors of the erythrocytes, megakaryocytes, and there's the lymphocytes. It's a carcinogen as well.
Right.
So it can cause this sort of.
So actually I've seen the literature, and for the alcohol, there are lot of papers were there that acute alcohol intoxication would lead to this pancytopenia because of myelotoxicity, and the patient would actually may develop MDS, myelodysplastic syndrome, and even aplastic anemia. Cases have been reported with acute alcohol, binge alcohol, and the patient could land into this. But surprisingly, the patient actually had left alcohol for last 7 days, because in 7 days this pancytopenia persisted. Because if you leave alcohol, the bone marrow start recovering at time, and after 7 days, 10 days, the patient would start improving in this profile also. So actually, there's something going fishy somewhere, like so we need to investigate. So Dr. Rohit, if this CBC comes with you, so would you like to see a marrow? You would like to take radiation because of infections and just treat with antibiotics and just wait?
Actually, if there is pancytopenia, and if there is no spleen, and if there is a history of such a toxic insult, you have to rule out aplastic anemia or MDS. So you have to for sure do a marrow.
Right.
These are the highest differentials. And sometimes leukemia can also happen. The incipient stage of leukemia can also present like this. Sometimes there is no hematocytosis or lymphadenopathy, nothing. But it can be, AML that can be masquerading in the marrow. AML like myeloid malignancy probably.
Right. So this patient, and actually we were all shocked at what is going to this patient, and I don't know what will happen. So we just have the peripheral smear. And I think it's always important to look for peripheral smear as well. And sometimes we do advise CBC, but in CBC peripheral smear wouldn't come. If you write complete hemogram, the whole picture would be very clear in the patients of hematological issues, right? So we did the peripheral smear, sparsely distributed RBCs, mostly normal anemia, where MCV is also normal. Leukopenia with marked this leukocyte leukopenia with marked leukopenia, platelets were markedly reduced, and no abnormal cells and hemoparacyte was seen. And I think leukemia could have been
Yes.
ruled out by the peripheral smear as well.
Yes. So, yes, the peripheral smear generally rules out leukemia, but sometimes even there are no blast, but sometimes the marrow can be packed with blast, and there would be no blast in the peripheral.
Leukemic leukemia sort of.
Yes. So in case anyway, you have to do a marrow.
All right. So instead marrow is required.
Yes.
So actually we just hydrated the patients, and it was other investigation which were available with us. The urea was 86, creatinine 2.3. Definitely the patient had AKI because of dehydration. Sodium potassium was low on the side, 129, 3.1, possibly because of fluid loss. Bilirubin was 2.1 and diet was 1.7, and OTPD was 310 and 76. So in alcohol, Dr. Vibhu, there is a difference between SGOT and LGBT. I think SGOT is more than LGBT in alcoholic liver disease.
All used is EST more than AU.
Yeah. Okay.
It can happen so in cirrhosis also. So when the patient develops cirrhosis also, this factorization is lost.
Okay. So it means the SGOT is more.
Extra-hepatic insult also. We will find this is in daily or in the patient who has that sepsis. This kind of patient will find found even in the blood.
Right. Since sepsis SGOT is more than LGBT, in fact,
Because it is extra-hepatic.
it might go to acute viral hepatitis, because in hepatitis the LGBT is AST is more than ALT. EST in viral hepatitis.
So if there is only liver specific insult, ALT will be more than EST. But if you have something sepsis involving lots of organs, then you patient the septic shock, etc.
So you can make a differential just looking at the LD and ST. it is the primary liver insert or extra liver insert. Then this total albumin was around 3.1, definitely the lower side, and it would be because it's a negative infant marker. Any sepsis would lead to low albumin. The liver is okay, right? So the problem diagnosis that was made at acute gastroenteritis, severe dehydration with hypotonic shock with acute kidney injury, severe pancytopenia. We need to find out what is here. Possibility of alcohol hepatitis because LFTs were deranged, and peripheral neuropathy alcohol related to this diagnosis I made up in the mind, right? So we just know what further that what is the cause of this small severe pancytopenia, and I consulted Rohit. So I asked Rohit what we should do. So he said that definitely this patient would actually require a marrow examination, right? So so just 2 slides of how you approach this, because we do see a lot of pancytopenia, and in the examination also I found this dark knuckles, right? And that was shown in yesterday also, that the patient dark knuckles. So this is a sign of vitamin B12 deficiency. And sometimes vitamin B12 deficiency can actually lead to pancytopenia somehow. But the patient is febrile, so it means there's some amount of infection going on. So I saw knuckles, I saw B12 could also be there. So this is pancytopenia because of impaired production, peripheral restriction, or impaired production and peripheral restriction. We have aplastic anemia, then the bone marrow infiltrate disorders, like malignancy, granulomatosis disorders. Nutritional deficiencies are very common, like as we said, that folate deficiency, in vitamin B12 deficiency, and MDS definitely should be ruled out. Then peripheral restriction, we have autoimmune hemolytic anemias, venous secretion. Hemolytic was ruled out because retic count was normal, and this is direct bilirubin. Yeah, and DCT was negative, that we could take. Then there is impaired production and peripheral restriction like PNH. Then there is SLE, drugs, leukemia, then HLH, then transfusion-associated graft versus host disease infection. So these are the broad, overview of causes of pancytopenia, and how you approach. Definitely, you do all the basic tests. Like you do copper, zinc, Coombs test, vitamin B12, platelets, haptoglobin, folate levels. You do SP, this PEP, HIV, hepatitis serologies, ANA, ultrasound spleen, and this energy sequencing. Then you can have the consumption disorders, then production disorders, then peripheral restriction and impaired production. Then accordingly you can do. Suppose there's a production disorder, go to nutritional, then you have to go with nutritional supplements. If it is non-nutritional, you have to perform bone marrow then. In bone marrow, if there is, you have to see the cytogenetic fish, could be acquired aplastic anemia, hypoplastic MDS, or congenital bone marrow syndromes. Could be malignancy like primary hematomalignancy or metastatic disease, right? So this is how you approach to a case of pancytopenia, right? So coming back to the case, then we just work out because the patient had a dark knuckles. So vitamin B12 is 481. So I think vitamin B12 is as normal, folate is 20. It should be less than, it is normally up to 15. So I think it's okay. Ferritin was 1000. It is actually the lab report came, it was more than 1000. Sometimes labs actually don't give you the exact figure of ferritin. They say it is more than 500, more than 1000. And if you see a patient like this, you have to call the lab and you have to ask them to give the exact figure. That it could be 2000, 3000, 4000, right? The report came to me, it is more than 1000. It could be anything, right? That means ferritin is raised differently, and ferritin is the acute inflammatory marker. So we expect that patient of gastroenteritis and so many things, the ferritin would be high. Then wild marker, the HIV, HBC, HCV, it came out to be negative. ANA, because of rule out autoimmune, hemolytic, so then it was also negative. DCT was normal, so no hemolysis going on. LDH is 900. So LDH is actually still high, and we have seen high LDH in vitamin B12 deficiency as well, with some amount of hemolysis going on. So you could give light to high LDH, and INR was around 1.43. So 1.43 could be related to sepsis as well, because liver seems to be normal in this patient despite of chronic alcoholism. So we did ultrasound, we see triple GB polyp, small peripheral lymph nodes, liver, spleen, and normal. So there is no spleen, there was no liver in background of this chronic alcoholism. So it actually surprised me that how liver is normal, right, in this patient. XHS, you can see this right zone infiltration. So some amount of infection must be going on, some viral pneumonias or something like that must be there. And that could be the cause of fever. And sometimes pneumonia can cause loose stools sometimes. Yeah. We have seen a lot of influenza patients, coming with loose stools. So that you can see this infiltration in the right lower zone, right? And patient is definitely hypoxic at present because saturation was 92% on room air. So this was the X-ray. So in the course of hospital review of severe neutropenia, patient was put on broad-spectrum antibiotics. Dr. Rohit, I would ask that we don't know the cause of infection. Patient of febrile neutropenia. So what is, what is your take on antibiotics and which antibiotic we should use? Because we don't know the cause. Because during culture, blood culture, their observation came out negative. Then what you should do? Do give antibiotics or don't give antibiotics?
So we for sure in any neutropenic patient we give antibiotics. We give a broad spectrum cover, and after 72 hours we have to add an antifungal. That's the rule.
Right.
So the neutropenia in this patient was significantly severe. It can be due to, it was probably due to some virality also. The CRP was not reached and the culture was negative.
150, 150, 150.
Yes, initial step.
150, 150 years.
So, but eventually it was specialized. So anyways, any, in a febrile neutropenic patient, you have to for sure start a broad spectrum cover, and antifungal has to be given homeless every towards relapse, and you have to do a serum collectomenon as well.
Right.
Sometimes. So if there's a chest infiltrate like this, you have to do a lot of fungal. Okay, so you probably have to add a broad spectrum antifungal on day 3 if the urine not controlled after getting the
Right.
Get the sleep, do not improve or these hypertension too much.
Right. So after 3 days, patient fever persisted, so we add fluconazole IV in this patient just to cover up the fungal issues. Then definitely, if this patient comes to you, you have to have the hematologist on board. Sometimes in small centers, hematologists are not there. You have to find a hematologist, right? And sometimes physicians are they become hematologists. But in this case, actually, hematologists have to on board. And I'm quite lucky that Rohit is with me, and Dr. Rohit keep on, telling us we are discussing this case because a very young patient, 37 years, presented with this thing. So we were quite perplexed at what should be done. So I asked Rohit. Rohit said that you give stat filgrastim and rosuvastatin so that see the response. If it is due to myelosuppression because of anything, because of infection, because of alcohol, the bone marrow start working sometime. So we gave one shot of filgrastim, 300 micrograms, this new kind, and then romiplostin injections for because patient has severe thrombocytopenia 25,000. And we actually kept the possibilities of alcohol-induced myelosuppression, myelodysplastic syndrome, as Rohit said, and aplastic. And we planned a bone marrow examination, no improvement. So we next day this came out after giving injections of filgrastim and this romiplostin. Hemoglobin was same 8.1, but you have seen the difference between TLC. TLC rose to 3,100 with 83% neutrophils, and platelets from 25,000 it was 50,000. So it means some marrow is still functioning. So we should do not aplastic anemia in this particular case because we have given this and the thing started improving. So actually we are dealing with some infection, some maybe because of alcohol, or maybe some other pathology is going on, right? So in this case, suppose if this is as per you to stop this filgrastim rosuvastatin and continue this injections, or then do a marrow. What is your approach after this report?
So actually, the logic of giving a filgrastim and a rosuvastatin was it was told to take care of any kind of infections because the neutropenic patients, they do not sometimes have any kind of fever, but the infections, are there and they tend to develop fever later on. It was the first purpose was to see the response of the marrow. If there was response of the marrow to filgrastim, then it means there was a stem cell reserve that was adequately responding. So, the leukemia, in leukemia, there's no adequate response to the, giving filgrastim. That was the first point. And secondly, to tide over any kind of acute infection. If the patient had any, because we tend to give filgrastim in case of any kind of infection to decrease the duration of sometimes.
So on 4th of August, we just repeat the CBC that hemoglobin is same 88, TLC again dropped 1700, DLC was 1724, platelets dropped, platelets died improved 64,000, bilirubin actually rose 5.1. So it means some amount of infection, sepsis going on, which is actually studied in the liver as well. OTPT is in the range of 289, 115, total protein, albumin actually now came low to low 1.8. So it means there is severe infection that actually we are tackling it. And possibly this infection is actually causing marrow suppression. So which infection, what infection, right? It's very difficult to, say this. And Dr. Vibhu is right that some GI infection is going on. Pneumonia can also sometimes, viral pneumonias can also give rise to such pictures. So we plan more marrow, and I asked Rohit to just elaborate in the slides. You can come here.
Yes.
So we did a marrow, and this is the actual marrow picture of the same patient. It's not from web internet. It is the actual patient of the patient, actual marrow picture.
Yes. Okay, thank you so much.
So,
Actually, if we see in this smear, actually, there are a lot of there are certain cells that we can see, And in the middle, actually, there is a cell which has a big nucleus, and there is a small, tiny little nucleus that we can see. So this macrophage has ingested a small lymphocyte, and beyond, just if you look at this cell. So there's a nucleus right here. So this is a small lymphocyte, and this little cell is a platelet. So the platelets have been ingested and the lymphocytes have been ingested. This is generally seen in the HLH actually. So if we go into the other slide, this macrophage, it has ingested eosinophil, it has ingested a platelet, it has ingested this is a lymphocyte actually, and this is also I guess it is a basophil. So, and this is a, yes, this is also, this is the main nucleus, and this is a lymphocyte. So it has ingested 5 cells, 5 or 6 cells, 1, 2, 3, 4, 5, 6 cells actually. So this macrophage, it is an activated histiocyte that is eating all the cells and is causing pancytopenia. So basically, the differential diagnosis based upon the smear was kept as HLH actually. So which can cause pancytopenia in fact. So we further, immediately after this report, I discussed this thing with Dr. Pankaj, and together we plan to start the patient on high dose dexamethasone. And once the patient was started on dexamethasone, his clinical, situation improved. We continue to do HLH labs. Clinically, he has been improving, except for liver functions that have been, affected, and because it is a systemic disease. So after giving Dexa, sir will further tell, what was the course of disease, and I will further, discuss the treatment options for this disorder.
So I think beautiful, and you can see this big macrophage eating all the cells, right? So normally, sometimes in HLH, you couldn't find it. This is not a pathognomic of HLH. You have a lot of other factors also. But if you could see this phagocytosis live in the marrow, so I think this makes sense. This makes more sense, I think. I was actually astonished to see the lab with the same patient, and we could actually see that particular phagocytosis going on, and we could make a diagnosis of HLH. So this is the report of bone aspiration report. The smear shows cellular traits. Megakaryocytes are adequately seen. Adequate poesis. The granulocytic series are cells are adequately represented, and 2% was blast cells, and lymphocytes within normal limits. Histiocytosis are very frequent, and many shows hemophagocytic activity that Dr. Rohit has actually just pointed out. This biopsy came out, and biopsy also showed that it's a normal cellular marrow, shows proportionate trilineage and hematopoiesis and interstitial prominence of erythrophagocytic histiocytes. So I think this makes a classical, picture of marrow of hemophagocytosis. And then we just go ahead and see the other markers. Serum triglycerides was 289, it was raised, but not so raised, but it was raised. Fibrinogen was low, 212. And NA was negative. So we actually look for the other cause of pancytopenia, HLH, to make a diagnosis of HLH. So final diagnosis is HLH. This is hemophagocytic lymphohistiocytosis syndrome. Just 2 or 3 slides of HLH. It is phagocytosis and macrophages of erythrocytes, leukocytes, platelets, and the precursors in bone marrow. And we have seen this beautifully in this slide. Very uncommon. I tell you, it is very common. We have seen few cases of, dengue-induced HLH in the previous epidemic, yes. Right? Yes. But it is very uncommon, right? Yes. So it is aggressive life threatening. Rohit has pointed out, you have to treat this patient very aggressively, because if you don't treat it on time, the patient actually will succumb, yes. Right? So it is aggressive life threatening. It is a hyperinflammatory syndrome, most common in younger groups, right, from infants and children, but can present in all ages. It could be primary and secondary. We don't talk about primary because it's seen in children and infants. Secondary, the causes could be infections, autoimmune, malignancy, immunosuppression. And this is the secondary cause of HLH. Infection, mainly viruses. Like, for example, this viral pneumonia causes, this could lead to HLH. Most common viruses are EBV, there's Epstein-Barr virus, HIV, CMV, there's malignancy, mainly malignant lymphomas. Macrophage activation syndrome. Sometimes they're confused with macrophage activation syndrome. It is not HLH. It is due to autoimmune disorders like SLE and rheumatoid arthritis. Other causes like organ stem cell transplantation, iatrogenic, vaccination, surgery, hemodialysis, and rarely seen in pregnancy as well. So this is all the pathophysiology you can see. There's a trigger, then there's T cell differentiated into natural killer cells, release interferon, gamma interferons. They stimulate macrophages to release the cytokines, and this all the cascade actually comes up. And you can see this in the slide. This is the slide which we actually saw in our slide. It is actually printed here. So it is actually taken from the net, and you can see the same picture in a patient as well. So clear presentation, normally patient have febrile illness, associated with multi-organ involvement. In the patient had AKI, patient has liver involvement, patient has hypertension, so patient presented with multi-organ involvement. Clinical pictures are similar regardless of whether an underlying genetic defect has been identified or not. Pictures are the same. So fever, hepatosplenomegaly, which was not there in our patients, then seizures and palsies patient can know the symptoms. Less common lymphadenopathy, rashes, and jaundice. These are initial tests that actually we have done everything in that, and we did the bone marrow. And this is a very important slide actually. How you diagnose an HLH, right? So diagnosis of HLH can be established if either one or two is fulfilled. Number one, a molecular diagnosis consistent with HLH. I think is available with us now. And other is diagnostic criteria HLH if you fulfill 5 out of 8 criteria. So 5 out of 8 criteria, number one is fever, splenomegaly, cytopenias affecting more than 2 lineages, hemoglobin less than 9, platelets less than 1 lakh, and neutrophils less than 1000. So this is the criteria. Then hypertriglyceridemia or hypofibrogenemia, which is there in our patient. Then fasting triglyceride more than 265, fibrinogens less than 1.5, hemophagocytosis in bone marrow or spleen or lymph nodes, low or absent NK cell activity, ferritin more than 500, we had more than 1000, and this soluble C25 is more than 2400, which we did not do. Supportive clinical criteria include neurological symptoms, CSF phagocytosis, conjugated hyperbilirubinemia and transaminitis, and hypoalbuminemia and hyponatremia. So hyponatremia is also there initially 129. So the DDs are macrophage activation syndrome, infection sepsis, liver disease, liver failure, MODS, encephalitis, autoimmune lymphoproliferative syndromes, and drug reaction with eosinophilia and systemic symptoms like DRESS. So what is the treatment, right? Treatment is to suppress the severe inflammation, for example, steroids, as Rohit pointed out, the high dose dexamethasone. We have cyclosporin A, we have intrathecal methotrexate if the neurological involvement there. The second is you have to kill the overstimulated antigen-presenting cells by etoposide, treat the triggering agents for like infections or neoplasm, and you use antibiotics and antivirals. So this is a treatment which is available in there, but in 1994, HLH therapy is ineffective with 90% fatalities, right? But now we have treatment for it, so we can see, and this is the treatment phase. This is dexamethasone. Actually, I could not find any treatment for HLH for secondary HLH. So these are actually treatment for primary HLH, right? Like dexamethasone, first 2 weeks, 10 mg per meter square, then third 4 weeks, 5 mg, then taper out 2.5, 1.25, and taper it to 0 over 8 weeks. So you have to give steroids till up to 8 weeks. Then you have etoposide with these doses. So that treatment, if the patient's showing symptoms, you have to continue this dexamethasone pulses, like for every second week, 10 mg per meter square for 3 days, and etoposide 150 mg every second week. So this is how. Other treatment modalities are like antithymocyte globulins, IVIGs, rituximab, and allogeneic hemopoietic stem cell transplantation. Everything fails, right? So I just asked Rohit that what is the role of IVIG in this case, and does it help this patient?
Yes, sir. So actually, this slide explains everything. And this case, was likely a secondary HLH, probably an infectious trigger. And, in this case, actually, we did give IVIG to, because the immune system was totally dysregulated. And, IVIG suppresses the aberrant immune response first, and it also reduces the T cell and NK cell pathway as well. So IVIG also suppresses the viral replication. So IVIG is a cooling down agent for the immune system. And secondarily, over here we will still avoid etoposide because etoposide is an immunotherapeutic agent, and in secondary HLH we tend to go up till only cyclosporin A. So we give DEXA pulses, we give cyclosporin, and we give IVIG to suppress the immune system, and then we follow the labs.
Right.
And in this case, I think in biopsy, this is a very important thing that we always have to see. Before starting the treatment, because you could be starting the patient on DEXA pulses, high dose DEXA, that there is no lymphoid aggregate in the biopsy. So if there is a lymphoid aggregate in the biopsy, then it is likely a lymphoma associated HLH. Okay, because there is a smoking history, alcohol history, then you still have to rule out lymphoma. But the thing is, the disease is life threatening, so you have to immediately start DEXA without compromise. But you have to look for the biopsy specimen, and if there is a lymphomatous aggregate, then you can put an ILC on it, and it would only automatically be a stage 4 lymphoma.
Right.
So you have to do that.
Right. So in EBV associated HLH, rituximab can also be used. This is also important. So coming back to case, we started with dexamethasone 8 mg IV twice daily. We started albumin infusion because albumin was quite low, 1.8, and patient is showing some features of NSRK as well. IVIG, we give a stat dose of 400 mg per kg, that is total dose of 20 grams. We started blood transfusion. We did not give blood transfusion initially, right? Because if we give blood transfusion, the picture would have changed, right? So we didn't give blood transfusion until we make a diagnosis. then definitely supportive care with, Udiliv and other liver support. And then on today itself, the patient is still admitted with me. So this is the today's report that you can see the hemoglobin went to 11%. TLC is around 3,000 now with 80% neutrophils. Urea creatinine has settled down. Platelets at 1.11 and serum albumin is rose to 2.6. So this is the today's picture, and patient is still admitted. Patient is now off oxygen, started taking orally. So I would feel that in another couple of days, we can actually taper it off dexamethasone and we can send the patient home. And I think it's a very difficult case that we have encountered recently because young patient, unexplained pancytopenia, unexplained fevers, and the bone marrow showing beautiful hemophagocytosis. And thank you very much. And just two take-home points. So HLH is an aggressive life-threatening syndrome of excessive immune activation. It is most common in infant young children, but can affect patient anemia. You have to be very, very much vigilant. If the patient comes to you, that you should rule out HLH. Most patients are actually ill with multi-organ involvement. Patient may have already experienced a prolonged hospitalization or clinical deterioration without a clear diagnosis, right? And many patients have predisposing genetic defects and on immunological trigger, right? So this is the take-home points, number one. Secondly, for to model the patient, we have to model the patient with ferritin, maybe,
Yes.
right? So yesterday ferritin was 1640, 1640. So still we are continuing dexamethasone. And we do the ferritin maybe every third day or fourth day, and then we can taper it off the dexamethasone accordingly. So it's a very difficult case, and I think some of you must have experienced this type of case, and it is learning actually for me to handle this case with the team of gastroenterologists like Viku and Rohit as hematologist. Thank you very much for taking a little more time.
Thank you. But what about counseling of the patient for TLA? High volume cancer, absent.
Now they have understood the graveness of the disease. I actually made it linked with alcohol. So I thought that this जो हो रहा है आपके साथ इसी साथ हो रहा है, and three sisters are there and they're there. So the patient कह रहा है कि आज के बाद में I will not take, and it's almost 7-8 days, 10 days also. He did not take more. So possibly this has actually given a lesson to him that alcohol can do a lot of other things also. Right. So probably the patient would not drink in life again. So.
One thing, sir, isn't it a standard rule in pancytopenia with such high ferritin think of excellence? High
degree of suspicion actually. High suspicion because we don't think about this actually. So actually the patient pancytopenia with fever, we should think about it, and I think we should actually look on the marrow. Because if we don't do a marrow, we don't make a diagnosis for it.
As a rule of thumb, pancytopenia with high ferritin, always think of excellent data marrow.
Right. Because ferritin is an acute infant marker. It can be there in any condition.
But such high ferritins ki more than 1,000 and
Yeah.
TGs are elevated.
Right. Think of it. That's
Is he still on the antibiotics?
He is on antibiotics right now. We have started on this piperacillin with the atypical coverage of doxycycline. So he's on doxycycline and piperacillin. And there was for past 7 hours he's not having any fever. His oxygen is off and has stuck a little better. Hemoglobin is raised to 2.6. So we just cross our fingers that patient actually would get better.
Sir, antibiotics ongoing. Doctor, Pankaj would be telling exactly what
Fluconazole, yes, because we give it.
6 weeks.
Fluconazole maybe no, sir. 2 weeks would be sufficient.
Sir, we can actually sometimes in India actually what really happens aspergillus is more common. So aspergillus modes in the air are more common as compared to the candida. In US, actually the candida is much more common, and the antifungal combinations in US is fluconazole and caspofungin. But over here, voriconazole comes up as compared to the fluconazole because the resistance is pretty high. So we tend to do serum selective manner. If there is a lung infiltrate or a CNP, CNP-9 cell pigmentation, we are doing as a trigger or any fungal infection that we are triggered to, so we tend to do and then we tend to fluconazole. So fluconazole works well here, and the patient is storing because we start with the lower antifungal first, and see the response the patient is responding. So probably the expert may be responsible to the.
Thank you very much. Directly, this time of all I know. Yes, sir. So the diagnosis is essential to
we can you have to do a bone marrow because with elderly patients, what really happens is if they are lymphoma T, NK cell lymphoma, or a histiocytic neoplasm, or or secondary malignancy that is infiltrating the marrow to with to rule that out, because you will get steroids and that malignancy will be wiped off. You never know whether you have enough material to put a immunohistochemistry marker on the biopsy specimen. So in this case, if I still want to do anything, like if I think that it is a lymphoma, okay, then I can still do a AFC panel 6 or 4 on the biopsy specimen to see whether it was a lymphoma or not, for tailoring the treatment. So if it's a lymphoma, then we can diagnose the lymphoma and give R-CHOP, and it would be a secondary malignancy associated HLS, then you have to treat the underlying malignancy. But over there, this patient did not have lymphadenopathy, did not have hepatosplenomegaly, and he had pancytopenia. So elastic MDS and his monocytes were raised in the circulation. So CMML was also a differential. Chronic myelomonocytic leukemia was also a differential here, along with MDS and aplastic. So the marrow had to be done because the pancytopenia was there, and CMML there is a immune cytopenia. So immune cytopenia, before you give any medicine, if you are giving steroids, you for sure need to do a marrow. And the thing is, the marrow along with the secondary malignancy will also tell any kind of any kind of myeloid uterine neoplasm that is hiding in the marrow, which is common.
Because there is a malignancy associated with HLH also, right? Malignancy can actually give rise to HLH. So marrow in this case actually would wanted actually to do a marrow this particular. Yeah, most of time, because if you didn't do the marrow, all the other 5 was actually meeting the criteria. Right, it was there actually. Without more marrow, yes.
Yeah, they were meeting all the criteria, sir, but alcohol and cigarette smoking was there. So you have to do a secondary malignancy, like any leukemia or lymphoma. So in any case, they have to do a marrow. In children, actually, it's more of a genetic thing. So this is a patient who is admitted with Biscuit syndrome, so actually he has CNS HLS. So in these cases, sometimes you can avoid the marrow even, because you can do a genetic study, the NGS, and you can look for a mutation and you can upfront standard treatment for HLS. So you can do a full exome sequencing for HLS markers. In this case, we will not find anything. Actually, the flow you do not need a flow here, and still we are sent a karyotyping, we have sent the biopsy.
I think we must document, Doctor. Collective list of consultants,
So my take would be that involve the hematologist or gastro or whatever, but only in the course of disease, because if you become late, this patient would have deteriorated. Yeah, I think it's very important. Very important. And our EDPA, WhatsApp group is always available. If any doubt, you can put in this thing, and definitely everyone would be able to help you out. Thank you very much.
Thank you, sir. Thank you, Dr. Rohit, for the wonderful discussion. I request Dr. Anil Chaturvedi, sir, to kindly facilitate the speaker in the discussions.
Okay. Sure.
So our next presentation is by Dr. Setu Gupta. He's given a really tongue twister for a title. So we'll go for the second presentation. It's a tale of triads of terrible tumor. Dr. Setu Gupta is consultant endocrinologist at Sri Gangaram Hospital. The case will be chaired by Dr. Neeti Agarwal, consultant endocrinologist, Max Padparganj, and Dr. Himanshu Sharma, head Department of Endocrinology, Rajiv Gandhi Super Speciality Hospital. I request Dr. Setu to start with the presentation. Another 2 minutes.
You are business and I went to our work. ये तो मगर तीसरा काम है, not but the least number one. And see, the alliteration, a tale of trials of terrible tumor. What an alliteration!
Thank you, sir.
Very poetic,
Thank you, sir. Can I request Dr. Himanshu and Dr. Neeti Dumam to take the seat? So from a case requiring multidisciplinary approach, I present another case requiring multidisciplinary approach. So yeah, so what were the tale? So I'll take you through that story. So we had case 1. He was Master MJ, 9-year-old male, student of class 5, presented with headache for 1.5 months. Headache was in the occipital region, episodic, severe in intensity, and associated with nausea and got relief with painkillers. So it was a 9-year-old boy just with headache. He was taken to his family doctor, and then there, for the first time, he was found to be hypertensive. BP was recorded to be 140/100. on both upper limbs on more than 3 occasions. So for a 9-year-old, it was definitely an hypertensive. He was managed with multiple antihypertensives like prazosin, enalapril, metoprolol from outside hospital. Where he was in Himachal, he was evaluated for young onset hypertension, and they did a really good workup. They did an USG, KUB, a Doppler, renal Doppler. First time, sir. They did a renal function test. Also, a renin and aldo levels were done, which were normal. So he was eventually, when they could not figure out anything, he was asked to undergo a CT abdomen, which was off the protocol, but then nonetheless, a CT abdomen revealed a 4.4 into 3.3 centimeter heterogeneously enhancing lesion in the left retinal gland. So, a very characteristic suprarenal mass was seen, and ophthalmologic checkup was done, which suggested no hypertensive retinopathy, which was also seen in echocardiography. There was no evidence of past hypertension in the form of no NPH. So, this is the CT scan. This is the right kidney, this is the left kidney, and there is a heterogeneously enhancing 4.5 centimeter mass, which is heterogeneous, which does not have a really defined capsule. And there were no specks of calcification that were seen in the fibers. So obviously, once the CT was there and the young hypertension was there, they got a biochemical evaluation. Ideally, this should have been the step 1 before the CT was done, but no matter what. So we can see that 24-hour norepinephrines were elevated more than 10 times from the upper limit of normal. So a clear-cut diagnosis of left-sided pheochromocytoma was made. Nothing out of ordinary for this. He was referred to a urologist, and for that they came to Gangaram, and then eventually I was involved in their management. So we preoperatively optimized the patient, and then he underwent a lap adenectomy on 7th of April 2024. Post-operatively, BP was stable without any hypertensive. So this was the mass, almost a 6 centimeter mass that was that we had resected. So further on, because it was a 9-year-old boy, he was counseled about genetic testing and advised a whole exome sequencing, and he was found to be heterozygous for VHL gene on exon 3. So now it was a left-sided pheochromocytoma on the backdrop of VHL syndrome. So following the event, his sister, which is Miss Disha Joshi, 16-year-old female, was then kept on close monitoring by the family members. Actually, this had started 2 weeks before he got operated, because she was also complaining of headache. So she was found to have hypertension with multiple readings of more than 160/90. And on the day we were discharging the brother, and the family informed us that even the sister is having high blood pressure. So we advised the patient to get a urinary metanephrine testing done. This was before the genetic test had come, because we had just sent the sample. It usually takes around 4 to 6 weeks for the report to come. So even before we had the genetic diagnosis of VHL, the sister comes up. The family told us that even the sister has 160/90. So we were not sure about VHL at that time. Biochemical investigations done. They were staying in Delhi. They had come from Himachal, and very clearly the urinary metanephrine was also elevated. So we got a CT scan done for them, and they had a bilateral adrenal mass on CT. Right side, it was 4.5 into 4.4 centimeter. On the left side, it was around 1 centimeter in the body of the left adrenal gland, and around 2 centimeter on the lateral limb of the left adrenal gland. And they were both arterially enhancing with heterogeneity. So they were features suggestive of bilateral adrenal pheochromocytoma. And a Dutanov PET was also done, which showed similar avid lesions. So as you can see, on the right side, there is a big 4.5 centimeter mass, and on the left side, there are small 1 nodule here, which is on the right side. And similarly, the other nodule here. So we had 2 bilateral pheochromocytomas in this particular case. So this patient underwent robotic adenectomy, 1.5 adenectomy on 26, after 3-4 weeks. Now, the problem was that when on the right side we had to do an adenectomy, on the left side, when the surgeon went in, and obviously it was a robotic adenectomy, because now the problem was that she is a female, the family was concerned that they did not want as minimal scars as possible, so they opted for a robotic adenectomy in her case, which actually turned out to be a bit problematic, because intraoperatively, they could not identify one of the lesions on the left side. So the surgeon called me up, and we had a huge discussion, because it's a robotic adenectomy, so there is no tactile feedback. like robotic में tactile feedback नहीं होता. You just keep on exploring, but you don't get that proper feedback कि कहाँ पर है. And he was very scared. He did not want to render her completely off the adrenal hormones. He had a thing कि नहीं, I want to preserve as much adrenal as I can on the left side, despite me saying कि नहीं निकाल दो. He was of the opinion कि नहीं, I want to puberty progress नहीं हुआ, so I relented him. Even the family members were not willing to give consent for bilateral adrenectomy. So in that intraoperatively, everybody decided कि okay, we'll just do 1.5 adrenectomy. So this time the patient underwent 1.5 adrenectomy, and this is the specimen. On the right side, we took out the entire big ass tumor. On the left side, we just could only identify the tumor on the lateral limb of adrenal gland, but not a 1 centimeter tumor on the body of the adrenal gland. So we did a repeat Dotanok PET scan, which was done after 6 months, and the previously lesion noted in the body of the left adrenal gland remains unchanged. So it was this is the tumor that you can very clearly see, which is unchanged, which is the same size, and it is not DOTA avid. So we got a histopathology done for both of them. The tumor cells were positive for chromogranin, so it proved that it's pheochromocytoma, along with obviously a histopath background of Zell-Bellin pattern. Ki-67 proliferation index was low, and PAS score, which is a pheochromocytoma assessment score, was less than 3/21, suggesting that there was no malignant transformation. So this is a typical finding that we see in pheochromocytoma, what we call a Zell-Bellin pattern. You can see a lot of nuclei which are very visible, with a lot of gaps which are predominantly the fats and everything. So this is suggestive of pheochromocytoma. This was chromogranin positivity. As you can see, this brown stain is chromogranin. So wherever it is positive, it means that it is positive. Again, suggestive of a neuroendocrine tumor, in this case of pheochromocytoma. And this was the Ki-67 index, which was sparsely there. So it was less than 1%. So we also sent a targeted mutation for her, and she was also heterozygous for VHL mutation, and she was carrier for that. And post-surgery, her blood pressure was maintained only on bisoprolol 2.5 milligram OD. So this was the case 2. But then subsequently, the 36-year-old mother, Sushma Joshi, was also genetically screened, and she was found to have genetic mutation for VHL. Obviously, on the background of it, she had been hypertensive since 12 years. So at the age of 24, she was diagnosed with hypertension, and she was controlled only on 4 antihypertensives, full doses of ARBs, CCBs, beta blockers, and alpha blockers. In her case, because she had been hypertensive for 12 years and obviously was not controlled in the initial years, her ophthalmologic exam revealed grade 4 hypertensive retinopathy with evidence of retinal angiomas, part and parcel of VHL syndrome. So she was referred to an ophthalmologist and was treated with injection anti-VEGF along with laser treatment of retinal angiomas. So I'll just show you this. You can see the evidences of a grade 4 hypertensive. Okay, this is not very clear, but you can see copper wiring and all. And this was an angioma which has already been lasered. So this is now died down, and on follow-up, this is how the angioma is looking like. So basically, it was a very bad angioma. The photo, I don't have that photograph of this particular angioma, unfortunately. We got a CT scan done for her. There was a right-sided adrenal mass with necrosis and calcification, which was 3.5 centimeter in size. And we did a Dotanok scan, and we found that actually there was a bilateral adrenal mass. On the right side, it was 3.5 centimeter, but on the left side, it was 1.5 centimeter, along with arterially enhancing para-aortic lymph nodes. So this is the advantage of getting a Dotanok scan done. So there is a lesion here, there is a lesion here, and you can see very clearly on the right side, there is a DOTA ability that can be seen. As well as on the left side, there is a mass that is there. So we got the metanephrines done, 24-hour urinary metanephrines were elevated. So she underwent laparoscopic bilateral atherectomy with paraganglioma excision on 5/9/24. So this is the his diagram that we have drawn. 2 adrenal glands and a para-aortic lymph node. Para-aortic lymph node, which was actually a paraganglioma only. So post-operatively, BP was well within range, 130 by 135 by 85 to 90, with only on 1 antihypertensive amlodipine. She has been kept on medical management with physiological replacement dose of corticosteroids and fludrocorp. She has no signs of hypocortisolism and has been extensively explained about the emergency and stress dosing of corticosteroids. So we had 3 family members, 9-year boy, 14-year girl, and a 36-year-old female who had baseline pre-operative blood pressures on the higher side, and post-operatively the blood pressures were normal. Urinary normetanephrines, as you can very clearly see in all 3 cases, the normetanephrines were far elevated, which is a typical of VHL. In the boy, we only had a single mass. In the girl, we had bilateral adrenal masses, and in the mother, we had bilateral adrenal masses along with a paraganglioma. What is clear is that Dotanoc eventually did help to identify the paraganglioma and the left adrenal mass, which we missed out on Dotanoc, highlighting the importance of getting a nuclear imaging done in any cases of young pheochromocytomas or syndromic pheochromocytomas. Histopathology was clearly showing pheochromocytomas. So just a brief discussion about new onset hypertension. These are the endocrine causes of new onset hypertension along with other causes. So primary aldosteronism, pheochromocytoma, CAH, Cushing disease, acromegaly. So these are the endocrine causes, and then we have renovascular diseases, coarctation, and drug. In one of the other endocrine causes is hyperthyroidism and hypothyroidism. So we have around 6-7 causes of endocrine diseases that can lead to new onset hypertension. When do we suspect in a young patient without family history or patient with hypokalemia, severe hypertension, resistant hypertension, fluctuating blood pressure with paroxysms, and hypertension with adrenal incidentaloma? So these are the red flag signs where you have to suspect an endocrine cause of an hypertension. How do we evaluate? We get a plasma metanephrines, and no longer urinary metanephrines are in vogue. There are better and better labs assays that have developed over the years, which clearly justify the use of only plasma metanephrines. And also the fact that urinary metanephrines are cumbersome to collect, and most of the time patients are not able to give a full collection of urinary urine for metanephrine estimation. We have to do plasma aldo and plasma renin in almost all patients, a thyroid function test, an overnight DEXA suppression test to rule out Cushing disease or Cushing syndrome, and a kidney Doppler. So just a very brief about pheochromocytoma. We all know it's a catecholamine secreting tumors that arise from the chromaffin cells of adrenal medulla. And there are several familial disorders associated with adrenal pheochromocytomas, and all of which have autosomal dominant inheritance. So when do we test for syndromic? For pheochromocytoma, when the patient has a classical triad of paroxysms, when the patient has a family history of pheochromocytoma, any hypertension with an onset of less than 20 years, or any resistant hypertension, any familial syndrome that predisposed to catecholamine secreting tumors, like if you have a MEN1 syndrome or a MEN2 syndrome in the background, a patient already has been operated for medullary thyroid carcinoma, and you suspect that the patient is having uncontrolled hypertension, always screen for pheochromocytoma. And a new addition that has been done in the latest guidelines is lipid poor adrenal incidentomas with or without hypertension. And what's the definition of lipid poor? And unenhanced CT attenuation of more than 10 HU. So this is something that I really want to address to the audience here, is because we keep seeing a lot of incidentalomas, adrenal incidentalomas with an HU of more than 10. Always suspect pheochromocytoma if the patient has hypertension. And when do we suspect genetic causes of pheochromocytoma? Almost similar, any young age of diagnosis of pheochromocytoma, a bilateral PO, any patient with paragangliomas or features of associated syndrome. For example, in MEN2A, you have MTC or hyperpara, or in MEN2B, you have MTC, marfanoid features, or mucosal gangliomas, or in neurofibromatosis 1, like cafe-au-lait spots, mucosal and cutaneous neurofibromas, Lisch nodules, etc. And the frequency is quite high. So, in MEN2, we have almost 50% of patients will develop pheochromocytomas, whereas in VHL, 10 to 20%. And the least prevalence is with NF1, where it's 2 to 3% incidence. So preoperative care, how do we optimize the patient, is that we want a target blood pressure of less than 130/80 and an upright systolic pressure of more than 90. And antihypertensive should be initiated at least 14 days before surgery, and surgery should be postponed if blood pressure control was not completely achieved. So different guidelines recommend different things, but Endocrine Society, what they say is very clearly that you initiate alpha blocker and high sodium diet. Always remember that it's a paradox that in uncontrolled hypertension, we are asking the patient to have high sodium diet. This is because We want that once the patient is operated and the adrenal veins are clamped, the BP is gonna shoot down. So you really want intravascular resistance to prevent hypotension post-operatively. So this is something, a paradox, but then you initiate alpha blocker and high sodium diet. You keep titrating BP goals until the patient either develop alpha blocker side effects. If they do, you add calcium channel blocker, and you keep doing it until the targets are met. If there is persistent postural hypotension, you increase high sodium diet or fluid. So you have to give fluids. Usually what we do as a protocol is overnight we give 1 liter of fluid. Nonetheless, so normal saline around 1 to 1.5 liter, we do transfuse to the patient overnight the day prior to the surgery. And if the heart rate is above target, we always add beta blockers. So this is what the Endocrine Society says, but practically a lot of other guidelines says that despite not having heart rate above target, it's always a good choice to keep the patient on some beta blockade nonetheless. The heart rate targets are heart rate 60 to 70 seated and 70 to 80 standing. The 70 to 80 standing is also essential to prevent postural hypertension. So if the heart rate is not rising and you are giving so much alpha blockade, then the patient will tend to have a lot of postural hypertension because the heart rate is not rising to prevent to maintain circulation to the blood. High sodium diet we encourage, and pre-anesthetic hydrocot infusion is recommended for bilateral aneurysms because obviously you're going to render the patient hypocortisolic post-surgery. And just a couple of slides about VHL. It's an autosomal dominant syndrome. It's present in about 1 in every 36,000 live births. Can occur in any age, childhood, adolescent, adulthood to even elderly. And it's a tumor syndrome. It involves multiple body symptoms. So what does it all involve? In the cerebellum, we can have hemangioblastomas. In the retina, we have hemangioblastomas. We can have endolymphatic sac tumor. I have had patients who have lost their hearing because of this and have been identified because development of endolymphatic sac tumor. The ENT surgeons took the patient to operate and the patient ended up having a high blood pressure spike. And that's when they call an endocrine consult in the post-operative period. And then we have hemangioblastomas in the spinal cord also. At the adrenal glands, we have pheochromocytomas. A lot of neuroendocrine tumors that occur in pancreas and kidneys, and then particularly in epididymis, we have papillary cystadenomas. So because of all these neurological tumors, it's a good idea to always screen the patient every year or every 3 years or every 5 years, depending on the age, for hemangioblastomas from brain to spine. So we do that. We have done that for that particular patient also. I have removed the screening protocol because I thought that it will be too much for the audience. Just a very small brief type. We have 2 types, type 1 and type 2. Not really relevant in today's world, but these are the classifications that have been done for VHL. It's based on genetic development and the risk of developing pheochromocytomas and RCC. So take-home message in the end, VHL is a rare disorder with a high penitence and a high suspicion of endocrine causes should be kept in any young hypertension. Main point is young pheochromocytoma should always be screened for syndromic associations. But the most important part is that preoperative optimization determines the operative course and outcome in pheochromocytoma, which is what a lot of surgeons tend to forget. So with that, thank you.
Thank you very much. Because we went for a very exactly enlightening talk on the subject, and I'm reminded of 1975. I know the registrar in medicine in hospital. At that time, we diagnosed pheochromocytoma without CD, without transform, only a urinary VMA and cortisol levels were clinical. And the surgery at that time, 50 years back, took almost 8 to 10 hours because it was very difficult to control the blood pressure. We had to call the cardiologist, Dr. G.D. Gupta, who was an associate professor in cardiology in GPAL. He was in the OT because the blood pressure was so fluctuating in that patient. But ultimately, Dr. Anand Vikas performed the surgery. So you have reminded me of that 50 years old, and I'm very happy that a young man. See, a tale of trial of terrible human. What a literature. Thank you. I'm a literary man, and I appreciate this. Otherwise, I had to go to friends for me. I will mention, but I thought this a tale of you should all, we should all, when you present the cases, bring such things, so exciting. हमारी जिज्ञासा बढ़ती है कि tale of trial of courage people क्या चीज हो सकती है. Secondly, was the whole family from part?
Himachal, sir.
Yes, that is another important. That patient was also from Uttarakhand.
Uttarakhand, actually, sir. Yeah.
ऐसा from experience.
बिल्कुल, sir. उस समय नहीं था.
One comment I would make,
Sir.
certainly, relaxation to be able to manage and actually, convince the family to get into such detailed investigation. One comment, I would say that although Dr. Setu has put down the history of hypothyroidism as a cause of hypertension, it certainly is there in young children, but for young again, really young again patient. So I had seen simple RMS at my residency days. So उसके अंदर again there was a patient child similar age group, I don't exactly remember the age group, but it was the child who was son of of a staff. So and we had a tough time because Shikla is simply was my hypothyroidism and it was also not pure hypothyroidism, like subclinical hypothyroidism. And we started levothyroxine and within 3 days it was so that even when it comes down the list, certainly it is there.
Yes, ma'am. And particularly for hypothyroid hypertension, always remember it's gonna be predominantly diastolic hypertension. That's a very peculiar thing about hypothyroid hypertension.
Second thing, another thing like the robotic surgery, right? There also, again, now the newer recommendations are that you don't need so much of, well, we are also doing it, like really just scared and then, but the newer recommendations are that you don't need so much of preparation because there is like less of preparation. So, although we are also doing similar preparation, so हम पहले open किए करते थे, but in the later literature, there is some preparation by the
No, ma'am, I disagree with that because in all three, I overlooked their preparation. They were absolutely meeting the Roizen's criteria, but Tino patients ke BP shot up to 240 intraoperatively. So this I do not agree. हाँ.
But if you go around searching, so with the newer, because there are less interventional surgeries now, so they are suggesting now that you can kind of, so that's why I'm saying,
Yes, ma'am.
they are suggesting that you go in for the lesser physician, but we are scared of,
Ma'am, more than us, the anesthetists are scared.
Even if it is a minimal invasion, but tumor handling is still there.
Yes. नहीं sir. Basically that patient I was involved afterwards कर दिया sir. उसमें कुछ नहीं आया. But I was not involved pre-operatively. That was the problem. Yes, ma'am. So follow that, ma'am. It's a very clear sign as the disease keeps on progressing, newer and newer tumors may come up big time.
There was more change even if you operate the
Yes.
I had a family in which one man at 46 was getting operated for his fifth with paralysis.
Okay. So that's interesting. Matlab, over the past 1 year, I have now a data of 16 pheochromocytoma. So I'm quite happy. I think eventually 30, 40 ho jayega, so we'll probably publish it another couple of years.
Genetic analysis.
Genetic analysis almost 50% ka ho gaya hai, sir. And almost 50% of them, so I would say out of 16, 7 का हो चुका है, उसमें से इन 3 को हटा दो तो 2 और हैं जो syndromic POs आए हैं, which fits the definition. कि 40% to 50% will have a syndrome.
10%
हाँ, हाँ.
Great, Setu, great presentation and good reminder for we physicians to be aware of all these endocrine causes of hypertension. Again, I was just listening that that suppression test, that's a suppression test that we do, has some false positives, which are again what we as a clinician see: obesity, alcohol,
Yes.
and stress. So overnight lateral suppression test has these false positives. So how do you take care of that?
So, sir, obesity and alcohol, so definitely it's recognized. Stress, physiological stress, as far as even if it's a physical or a mental stress, should not lead to a false positive DEXA suppression test.
These are the
Physical stress, neither the mental stress, neither the emotional stress. No form of stress should not be suppressible. Matlab, stress ultimately is a physiological hypercortisolism.
what over that's why you are using. If you
हाँ.
are using 1 milligram, that is
नहीं सर, so उसमें obesity के लिए there are cutoffs that have been defined कि for example if the patient is 90 kgs above, you may have to go even do a 2 milligram DEXA suppression test instead of 1 milligram. So 1 milligram में बहुत सारे लोग 90 तक करते हैं, 90 के beyond 2 milligram करते हैं, but I don't think हम में से कोई ये follow करता है. So but it's there sir, it's there just for that particular कि false positive हम rule out करें. In case the DEXA do come positive, I tend to do a LGDST because I think it's much more cheaper than getting other tests for Cushing's done. So I just get an LGDST. Majority of the time LGDST rules out these false positive and I am sure कि ये Cushing's नहीं है. And alcohol में तो है sir कि 4 days of abstinence, 4 to 5 days of alcohol abstinence is good enough to repeat the new NDST.
Particular case, I think, it reminds us of previous days where you used to actually read people, but you don't see any people in the rate that is. Right, but actually now the videos have been coming up, right, and we are now using time because what the criteria are there.
Yes sir.
Right, so my, just, the comment is, that do you have the, your extra layer, that is primary now, for primary plastic without putting any condition? Because we had a case recently, young guy, 10 years, had a, so this, superior, these are supposed to be there, sitting around. And when we were doing ultrasound, there was a private class, right? And we did a PET and it was defined that it could be a carcinoma. So we get a marker of that, all the markers came out to negative, and patient was double tested. So on Monday, the patient is going for the surgery, but then the period not comes out to be. So PET was actually very suspicious of carcinoma. But patient had no signs of, any kind of carcinoma.
I have a point in that the superior vein thrombosis that the patient had, because of which he was admitted. Did we rule out a head and neck paraganglioma?
It was PET was done before.
But did they particularly look
PET also, I category said was very common, have the
paragangliomas and heat?
to split it.
Yes
So
sir.
there's some evidence made, but they were not very clear and could be corrected. So I think that surgery would actually make a diagnosis, right, what was there.
Right.
We, and patient got better of this global weight happened, became normal, followed by this, DOAC, and patient is not getting better. Now he is all 5 days off, DOAC, and he will operate tomorrow. Day after tomorrow, and let's see what comes out.
So it's common, sir. The paragangliomas can be non-secretory. It's just a neuroendocrine tumor. It may not necessarily be secretory. Right, sir. So one more thing, just a take-home point that I think missed. Do not do urinary VMAs, urinary metanephrines, nor metanephrines. They are not required anymore. A plasma metanephrines, a plasma fractionated metanephrines is the best investigation to be done. No preparation, nothing required. Just ask the patient not to have coffee for 2 days, chocolate for 3 days, banana for 3 days. That's all. And whenever they're drawing the sample, ask the patient to lie down for 15 minutes. वो लाल पाथ लैब में जा रहा है ना, उसको बोल देना भैया लेटे बिना सैंपल नहीं निकलवाना है, कुछ नहीं मिले तो जमीन पे लेट जाना, बट वहीं लेटे लेटे सैंपल करवाना है.
And we did the same, they're doing the same in this patient. Right, this is the way that we should do it.
Yes sir. Thank you.
Thank you, Dr. Setu. I now request Dr. Paras to felicitate the chairperson and speak.
Sorry? No, sir. Nothing. Whatever the patient is on, continue with that, sir. कुछ नहीं, कोई जरूरत नहीं. No, sir, no. Coffee, banana, chocolates, any form of, and nicotine, sorry, because it's also stimulant.
अरे भाई ताता फोटो खिला दे यार इतनी फोटो ले लो बोले
हाँ, ऑफ एंड ऑन चलता ही रहता है।
एक रिक्वेस्ट मैं भी करूंगा on behalf of EDPA Silver Jubilee Year celebrations would go on and we all have to contribute to some community health, right? One of the projects that we are taking at EDPA is Smile. We'll share more details of it on EDPA Academic Wing and Life Members Wing. We're just preparing some